I'll wait for the message to stop. Well, this is a nice occasion. I'm trying to share my screen, but that doesn't really work yet. So let me try again. Yes. So welcome everybody. We're honored to be able to be with you, although it's virtually this year. We were looking very much forward to go to Brazil, to Porto Alegre, to meet all of you, but well, obviously the Corona pandemic has been a game breaker. So today I will start with a brief introduction of the course and the rules that we adhere to during the course. And we as the teacher team will introduce ourselves to you. So the first thing is the Zoom rules that we generally have with our students. So please, if you're not speaking, mute yourself and be sure to be on time so that we can also start on time. It's a bit difficult because of the different time zones, but that always helps for the class to start on time. As Angela already introduced and Ayrton, we will be recording at least some of the meetings so that really the content meetings will be recorded. And some of our PhD students will be teaching as well in some of the sessions, and they also need the recording for their teaching course. So they are in training to become a teacher, and they need the recordings to share with their tutors. So I hope you don't object to that. If you really object to that, then you can turn off your video, so then no one can see you. Although I think it's only the speaker that's being recorded generally. So for the course schedule, today we have a bit of a different schedule, but generally we will start with a short plenary session. Then we have working groups. Then for you it's lunch break, but for us it's dinner time. And you will continue with the computer practicals that will be supervised by Gisela and Angela. So this is basically the course schedule for the upcoming 4 days. And then on the final day, the Friday, we will end around 12 with a plenary session, with a closing session. Hanneke and I will say goodbye to you then. And then Gisela and Angela will still be there for the last computer practical. Angela, can you pick up here?
Yeah. So for the master's and the PhD students, we have 3 main assessments. So they are basic quizzes that you need just to complete them on Moodle. And if you complete them, you got 2 points. The second assignment will be the critical appraisal of economic evaluations using CHEERS checklist. So if you do that and upload on Moodle, you got 2 points as well. We will discuss all the answers in the working group. So all the answers will be available for you. And the third assessment will be a full economic evaluation and critical analysis. And you are supposed to do that in the computer practical with me and Gisela supervising you, and we will guide you through that. And so at the end of the computer practical, you just need to upload your answers on Moodle as well. And this last one will be graded, and the grades will be available on 20th of February then. Yeah.
Thank you, Angela. So if there's anything unclear, if you have questions, you can use the discussion board on the Moodle platform, or you can send an email to Angela or me, and then we'll hopefully be able to answer your questions. So are there any questions about that? About the practicalities?
I would only add that if you have any problems with Moodle, you can ask me and I will try to sort it out. But as far as I can see, everyone is accessing without any problem.
Thank you, Ayrton. Okay, so then a brief introduction. I will start with myself. So my name is Judith Bosmans. I'm a full professor methodology of health technology assessment at the VU, the Vrije Universiteit in Amsterdam. This is a very pretty picture of the building where we're based. Actually, it doesn't look that nice. But we're part of the Faculty of Science. Other departments in the faculty are, for example, mathematics, physics, but also informatics. So it's a very broad faculty with lots of different disciplines. So within the Department of Health Sciences, I am the chair of the research group Health Technology Assessment, and this picture was taken, well, I think it's already 1.5 years ago in Copenhagen, when we were there as a group for the ISPOR conference. And some of the people in this picture will also be teaching. So Ale Handra, who's here on the far left, Agni Baka and Anita Varga will be teaching during the course of as well. And of course, Angela, you already have seen or you already know. So a bit about the research that we do as a group. So we do a lot of applied cost effectiveness studies, and that can be trial-based economic evaluations or model-based economic evaluations, but we do a lot of applied studies. In addition to that, we also look into policy making, so how are cost effectiveness analysis used within policy making, and why are they not optimally used, or what are barriers in using them. So that's mainly, or that's something that Hanneke mainly does. We're looking at methodological aspects in the statistical analysis of trial-based economic evaluations, and this is one of the latest publications in that field, where we look at multi-level analysis within cost effectiveness analysis. And Angela is also starting a research line on quality of life assessments within cost effectiveness analysis. So it's quite a broad range of subjects that we touch upon within the research group. And here's a little, it's a picture of the network based on published papers that we have. And you can see that we work a lot together with Maurits van Tulder, who was the previous professor within the Health Technology Assessment Group. But we also work quite frequently with Professor Osterlo, who is an expert in the field of musculoskeletal health. And you can also clearly see the different research groups that we work with, and of course Angela is a very important new research partner over the past few years. So Hanneke, can you pick up from here?
Okay, well, my name is Hanneke, but if you're trying to Google me using Hanneke van Dongen, then you will not find me. Because my official name is Johanna Maria van Dongen. So that's also on my scientific papers. A couple of years ago, or almost 10 years ago already, I started my PhD also at this department. And my PhD was about, this is also the cover of my PhD thesis, was about of worksite health promotion programs. So my thesis mainly focused on economic evaluations of interventions in occupational health. Well, as part of my PhD thesis, I conducted systematic reviews. One of them is on this slide. And I also conducted a qualitative study among peers, and that's also what you did briefly about, and that we also want to know what kinds of barriers and facilitators do decision makers experience when trying to use information from economic events. I recommendations article, trial-based economic evaluation health. And I also conducted a couple of applied studies, trial-based economic evaluations. And then this example was a trial-based economic evaluation in which we compared a mindfulness-based program versus usual practice. Okay, so this was my thesis. After my PhD, I stayed first as a postdoctoral researcher and now as an assistant. And in this capacity, I help and also sometimes conduct applied studies myself. Here are two examples. The first one is one about the effect of radio frequency denervation on pain intensity. I was involved in, I was also, for the trial-based evaluation, and I will, during the open session, will tell more about this trial, as well as the implications that it had on the Dutch public. But this intervention is still in the Netherlands or not. So this study had really large policy implications in the Netherlands. Well, also Gisela, who will also help with this, also a teacher in this course. She visited our department twice already. And during her first visit, I helped her with the trial-based economic evaluation in which she practiced exercise therapy for chronic low back and event to usual practice. And that was published as well. So these are the applied studies. Well, as Judith already indicated, next to applied studies, we also conduct methodological studies. The first one, I have some examples on this slide. Some of the examples Judith already briefly mentioned. But a couple of years ago, together with the European Union, about the health economic as well as methodological constraints in low back pain. And we wrote some recommendations about it. Well, then we also did a paper on what pharmacoeconomic guidelines recommend regarding analysis of trial-based economic. I also did research into the area of quality of life, but Angela is way better at it than I am, so she's kind of taking over that area, which is perfectly fine, and also more methodological work, what statistical methods are in the analysis.
Thank you, Hanneke. So then maybe over to the linking pin between the Vrije Universiteit and the UVixSPA, because we would never have been here without Angela. And I'm assuming that we will have a smoothly run course, and that's mainly thanks to Angela. So Angela, floor is yours, and thank you in advance for all the work you did for this course.
Oh, thank you. I'm glad to be here and to share all this experience that I have been doing here in the Netherlands and with you, Judith and Hanneke as well. And so I'm Angela. I'm a family physician and epidemiologist. And Judith and Hanneke are my supervisors in my second PhD here in the Netherlands. And they are supervising me in methodological and in applied cost effectiveness studies. And so one of the projects that we have together, we've been published articles on that, is assessing the impact of quality of life measures in countries and what the impact of using different quality of measures on cost utility outcomes. We also have been investigating, comparing scoring methods for utility values for measure quality of life. And this is the second paper. We compare crosswalk methods and value set methods and explore the impact of using these such methods on cost utility outcomes as well. And in the sequence, also, I'm lucky to participate in this paper that Hanneke has just mentioned about the National Pharmacoeconomic Guidelines, what they recommend regarding the statistical analysis of trial-based economic evaluations. And especially in Brazil, we found that the guideline mainly focus on model-based economic evaluation, and there is a lack of recommendations on trial-based economic evaluation. So I think this course might open a space so we can think about how to incorporate these statistical challenges or recommendations into the guidelines. And so I think it's a great space for that, so we can discuss that more. And of course, I've been involved with applied cost effectiveness analysis, for instance, comparing a dynamic work intervention with usual practices to reduce sedentary behaviors here in workers in the Netherlands. And my project, my title of my thesis, my second thesis, is Health-Related Quality of Life and Statistical Challenges in Trial-Based Economic Evaluations. And this has mainly three topics. We investigate how, if multiple imputation is necessary, along with mixed model analysis in trial-based economic evaluations, the impact of using EQ5D scoring methods on cost utility outcome results. But now we use simulated data because the article that we publish, we use empirical data from clinical trials in the Netherlands, but now we are simulating these other scenarios with other levels of diseases and countries as well. And also we are looking at the predicting and mapping quality of life from disease-specific outcome measures that usually researchers use in clinical trials, specifically in low back pain, the OSVAS-3 disability index. So yeah, I think this is it. I'm really glad to be here and to help you out in the working groups and share knowledge with you and learn from you, and with the computer practicals in the afternoon. So welcome.
Thank you, Angela. And maybe it's nice to mention that for the second project, so the impact of using the different EQ5D scoring methods, Angela managed to obtain a grant from the Yerkwohl Foundation to do that work. So that was a very nice accomplishment, I would say. So Ayrton, could you pick up from here?
Yes, thank you. My name is Ayrton Tetelbaum-Stein. I'm a family physician and a full professor of the Department of Collective Health and Health Science graduate program at UFSPA, the Federal University of Health Science of Porto Alegre. And we have been planning to run this course in Porto Alegre for a long time with Bridge University. And a good side effect of this pandemic that we are putting more emphasis on distance learning. And it's great to have Brazilians living in a foreign country, such as Angela, who has been very helpful to set up this link between our university. And it's great that several health professionals and managers from around the country could join us, and I would like to thank very much Rebratz, the National Health Technology Assessment Network, to supporting this course. It's very important to have this achievement for networking, to have a high-level course in international stage, and of course learn in depth economic evaluation. So this economic assessment for healthcare courses involve these two institutions, and I, in liaison with Karine, run the Health Technology Assessment Group at UFSPA, and we have research projects and methodology guidances in collaboration with National Network, EBRAS, and we've been developing a new version of a manual for guidelines of CONITEC, which is the HTA of Brazilian Ministry of Health, and how to implement guidelines in the Brazilian context. And I'm also involved in Guideline International Network, specifically the group work of ADAPT. So in 2020 and 2021, we developed a course in liaison with UNIFESP and UFSPA on science and COVID-19, which was very successful. Around 1,000 people were enrolled, and Raquel Hira, who is joining this course, was also involved, and Karine, of course, from UFSPA. And we developed three postgraduate courses in line with these topics that we're going to cover during this course: a guideline course, systematic review, and global health course. I was one of the authors of a methodology on synthesis of evidence for policy that was run by Brazilian Ministry of Health and AGACOR as well. And it has just been published a book that was the first achievement of this group, Angela, Daniela Pachito, Silvio, and Hanneken and Judith. The book was on integrating the organization of health services, workers, well-being, and quality of care. And the chapter that we developed was on digital health technology implementation. Is it effective in a healthy healthcare perspective? And I'm also in liaison with Daniela Melo from UNIFESP, and we have been developing several articles on evaluating the quality of guidelines. You can follow the next one. And three of the postgraduate students who are conducting economic evaluation are attending this course. The first project is on economic evaluation of academic detailing as a strategy to implement the HIV guideline in primary health care in Porto Alegre. Ana Amélia Bones is the PhD student. The second project is economic evaluation of a nudge intervention to reduce unnecessary use of radiography image for low back pain. Thiago Linhares is MSc student who is doing this dissertation. And the third project, prenatal care by telemedicine, effectiveness, economic analysis of technology incorporation and implementation of assistance protocol. Thalita Colombo, who is also joining us in this course, is conducting this PhD thesis. And we're working in liaison with Vrije University. So thank you.
Thank you, Ayrton. So Karine.
Hello, everyone.
Hi.
Let's introduce myself. I am Karine Raquel Blatt. I am pharmacist and full professor of the Department of Pharmacoscience at UFSPA. I'm a colleague of Ayrton and member of NATS at UFSPA. And I would like to say that I am very glad to be here, and I would like to say thank you so much for Angela, Hanika, and Judith, and especially to Ayrton, to opportunity this course for all. And I would like to desire very good time together. I'm sure that we'll be learn a lot about cost effectivities and health economic assessment with this group and a specialized group of we be here. Thank you.
Thank you, Karine. So this is from UFIXPA, but we also have Gisela here from Sao Paulo. So Gisela, could you introduce yourself?
Yes. Hi, everyone. Thanks, Judith, Hanneke, Angela, and Arito for this opportunity to be here with you in this course. My name is Gisela. I'm a physiotherapist and a postdoc researcher at Unicid, Universidade de São Paulo, supervised by Cristina Cabral. She's here today. And at FU, supervised by Judith Bosmans and Reneke van Dongen and Maurits van Tudor as well. At FU in Amsterdam. I was there in the last year. It was an amazing experience to do my research internship there. I learned a lot, yeah. My research area is economic evaluation since my PhD that I published 3 studies. One is a protocol and the other it's the results of a trial-based economic evaluation. And our systematic review with meta-analysis. Both are economic evaluations in the physical therapy field. Yeah, the next, please. And for now, in my postdoc, my project is about economic evaluation in chronic musculoskeletal pain. And it includes 6 studies, mainly 6 studies, because I have other collaborations with other research as well. The first one, it's a clinical study, compare different healthy state utility instruments in patients with fibromyalgia. A systematic review with meta-analysis about economic evaluations of no pharmacological treatments for fibromyalgia. A trial-based economic evaluation comparing Pilates and aerobic exercise in the treatment of patients with fibromyalgia. And the next slide. A masterclass article about interpretation of trial-based economic evaluation in physical therapy research. A cost of unit study about healthcare and absenteeism costs of osteoarthritis in Brazil of 2018. And an individual participant data meta-analysis about the longitudinal association between health-related quality of life and the cost in patients with no specific low back pain. And these 3 last studies I'm conducting with Judith, Hanneke, and Angela as well. Well, it will be a pleasure to help you in this week in the computer practicals. And I hope you enjoy this course. Welcome.
Thank you, Gisela, and very nice seeing you again. So this was the introduction by us. We would like to know a bit about you as well, but I think we cannot do a round like this. So what Angela and I came up with is that we do some brief Mentimeter questions with you now, just to get a gist of who you are. And then we'll break up in 3 smaller groups, so you can talk a bit about the research that you're doing and the reason for being in this course, and we'll wrap that up in a plenary session again after that. So I'll start by sharing the Mentimeter questions. Let's see whether this works. Can you see my Mentimeter questions?
Yeah.
Okay, so
Not the questions.
not the
Yeah.
questions.
Yeah, now.
No.
Yep. So if you go to menti.com and fill out the code 8105428, then you should arrive at this first question. So instead of asking your exact ages, we put it in age ranges. So please let me know if it doesn't work. There's something in the chat. So let's give it another 15 seconds or some. Only 15 answers in, 16. But I think that the main, most of us are between 30 and 50, which is close to our ages, I guess. So let's go to the next question. What's your background? So Angela and I try to come up with as diverse backgrounds as possible, but we may have missed some. So another 10 seconds. Okay, so most of you come from medicine, but there are also, we missed 2 backgrounds, Angela, so maybe who said other?
Yeah, please just let us know. Economist, Fabiana. Fabiana is economist.
Ah.
Oh, that's super nice. Yeah.
And the other one who chose other?
Biomedicine, Stephanie.
Ah.
So I will take note.
Yes. And well, quite some from pharmacy and physiotherapy as well. So it's nice to see so many clinical backgrounds as well. So then the next question is, what is your main occupation? So MSc or PhD student, researcher, healthcare professional, policymaker, or lecturer or professor? Nice. So lots of healthcare professionals, Angela. That's nice to know. And one policymaker and some lecturers. So what kind of subjects do you teach? Maybe one of you can unmute and tell us. Do you teach in medicine or epidemiology? Maybe one of the lecturers.
Hi, good morning. Hi, Judith, Angela.
Hey,
Monica.
Rodrigo. Nice seeing you again.
Oh, yeah, the same. Thank you. Yeah, well, I'm a physiotherapist, so I teach at the School of Physical Therapy. And my disciplines are evidence-based practice and mostly primary healthcare. But I focus on physical therapy interventions.
And do you still work as a healthcare professional as well, Rodrigo?
Yeah, I would like that, but unfortunately we cannot with all the activities and bureaucracy as professors and researchers as well. Within the
Yeah.
graduate program, it's complicated, but I miss healthcare activities.
And we have a HTA Health Economics and Epidemiology teacher as well. So that's nice.
Hey, I forgot Gisela. Hi, Gisela.
Okay.
I would like to have some words from Luis Correa, who is a very prominent lecturer in Bahia.
Hi, thank you, Ayrton. So I teach. I'm a little bit of except for PhD students, I'm a little bit of the other things there. So I do research in meta science, evidence-based medicine, and also clinical research in cardiology because I'm a cardiologist as healthcare professional. And also I teach evidence-based medicine and scientific thinking in the post-graduation program and evidence-based medicine in the graduation program. And we have a program extramural of the university that we try to spread this message of medical thinking based on science.
Really important. Thank you. And
I
you still do clinical practice as well?
Yes, I'm a cardiologist.
Wow, that's a lot.
Raquel
Yes,
Vieira is also
with all these things. Maybe the student is what we really are all the time and collect all the other classes.
Yeah. Yeah, but
I would like to have Raquel Vieira presenting herself as well. Raquel, are you here?
Hi, everybody. Nice to see you, Ayrton, and every teacher here. I'm very excited to learn with you. I'm professor in Universidade Federal de São Paulo. I teach medicine, the course of medicine and evidence-based medicine. Also to undergraduation students, but also to post-graduation. And I'm very involved in this topic, especially now in economics. I'm learning. I'm conducting some studies with a team that I coordinate in a private hospital here in Brazil, Hospital Sírio-Libanês. So I have this double role as teacher and also as a researcher.
Thank you.
A lot of interesting people, but I would like to have Thiago, who is now he's a Brazilian, but he is doing a postgraduate in United Kingdom. Are you here? Can you?
Yes, but I don't mean to be rude because my camera is on and off, and please bear with me because I am a person who stutters. So from time to time, I will block and it's my natural way of speaking. So I am a research scientist. I am currently based in the UK as a Chevening scholar in medical statistics at the University of Leicester, and I've been involved with some clinical trials and many projects in health technology assessment, and I am really thrilled to participate in this course because I am sure that we are going to learn a lot.
Well, thank you. At least you are in the same time zone as we are,
Yes.
Tiago.
Anyone else would like to share their occupation?
I think it's nice to see that it's such a diverse group that you managed to track to this course.
Yes.
Well, if you allow me, I want to share that we are in São Paulo too, and we are at the medical school here at the University of São Paulo, and the hospital, which is the major hospital in South America. We have 3,000 beds, and we are just doing a lot of research about economics, real world economics. We are now setting the electronic records for all the institutes. So it's a very important space we have now. And we have some students, one of them are here, Renata Lobo, and also people that are doing mainly performance evaluation of the programs, which is helping us to build a new strategy for research applied in the field. So we have results for the institution and for the healthcare system as well. We work with the health ministry also in the context of the REBRATS. And it's very pleasant because we have recently started a regional concentration on São Paulo. So it's the network of Paulista, which has also 35 hospitals together. So it's very important for us to have this link with you so we can have some students going also for exchange. Thank you so much for creating those participations and creating articulation. Thank you. Thank you to Ayrton too. Thank you.
It might be interesting to have a student, and I know Thiago Linhares can communicate well in English. So Thiago is an MSc student at UFSPA. Thiago, can you share your perspective?
Hello, can anyone hear me?
Yes.
Yes.
I'm sorry, I don't think my webcam is working right now. I'll see if I can fix it. But nice to meet you, everyone. I'm very pleased to be part of this course. I'm starting my postgraduate studies now. I'm a master's student here at UFSPA, and I'm studying health sciences. Ayrton is my supervisor, and Angela is my co-supervisor. So I hope everyone has a nice course, and I'm really looking forward to it. So thank you.
Good.
Thank you, Tiago. So maybe we can go to the next question, because Angela and I were wondering whether some of you, and I know that some of you do, but do you have experience already with cost effectiveness analysis? Okay, so it's a nice balanced group. So hopefully you can also learn from each other and from the experiences that the people who have done cost effectiveness analysis before have already. And then for a final question, so what do you expect from this course? And you can write a max of 3 free text words or short sentences. Okay, so I see a lot of words flying across the screen. So learning is an important topic, so that's good. But also I see learn about analysis in R, which is what we are going to do, hands-on exercises. So that's exactly, so the computer practicals are all about giving you the hands-on experience with doing cost effectiveness analysis. I saw something about putting value on health. So that's something, I think that's tomorrow, right, Angela? Exchange experiences, that's a nice one, because that's one of the things we will try to, yeah, to grow in this course as well. So please also share your personal experiences. If you run into questions when in doing your research, please put them forward either in the small groups or in the plenary sessions, so that we can learn from each other as well. Meet people working on HTA. Well, I think there's a nice group here is completely interested in HTA. I will start the critical analysis of economic evaluations. So I think we cover a lot of aspects here, right, Angela?
Yeah, definitely. I think we can definitely learn from each other. We are planning to work a lot on this. I think we are on the same page on the learning objectives of the course. Yeah, that's super good. Yeah.
It's nice to see, Angela.
Yeah, super nice. I'm thrilled here, just watching the cloud, and yeah, that's super nice.
Judith,
yes.
I would like to have Rafael Vargas, who is also a colleague of ours at UFSPA. Maybe he could just present quickly.
Yeah, sure.
Rafael, are you joining us?
I will stop sharing because then we can also see him.
No, not sure. Yeah, maybe he's not on the call. He's an oncologist, and his PhD was on economic evaluation, so it would be nice to have his inputs. But I think he's not on the call.
Yeah, he is.
Oh,
Sorry.
yeah.
He's on the beach,
Sorry.
right?
Yeah.
I'm sorry, but have some difficulties here. I have two children's, small children's in the beach. The lunchtime is even, and the cell phone. Okay, my name is Rafael Vargas. I am a clinical oncologist. I am an epidemiologist. I was a colleague of Angela in URGS, at URGS. And it's glad to stay with here. 1 minute. Okay, I'm sorry, but it's very difficult here now. Okay, I'm very glad to stay here.
Thank you.
Thank
So
you.
I suggest, Angela, can you, you're still,
Yeah, make the breakout rooms.
yeah, so I suggest that we have a 5-minute break, and then we, when you come back, we will go into the breakout rooms, and these are more about getting to know each other a bit. I'm sorry, we also have a dog. So that you can get to know each other a bit, and then because the rest of the week you will be stuck with each other, and then we can have a plenary wrap up before I will give you a brief lecture on the ethics of cost effectiveness analysis. So I suggest that we start in the breakout rooms at 2:30.
Yeah.
So we can have bathroom break, get a cup of coffee, and then start it afresh.
Here in Brazil, it will be 10:30.
10:30, yeah.
Yeah, I'm sorry.
Yeah, sure.
2:30
No problem.
CET, 10:30 Brazilian time.
Perfect. See you then.
Yes.
See you.
Presentation. So ethical aspects of cost effectiveness analysis, and I picked a few that during the courses we gave over the years have come up again and again. And the first one I would like to discuss is the inclusion of lost productivity costs. So in the Netherlands, the recommended perspective to take in any economic evaluation is the societal perspective, which means that you take into account the healthcare costs, but also patient and family costs and lost productivity costs. And the concern about including these costs, of course, is that you can that it can turn against people who are not economically productive anymore. So I have two examples of a healthcare intervention. The first one is a device to treat arrhythmias in adults 75 years and over. And the additional healthcare costs of this device are 10,000 euros. And obviously, or at least in the Netherlands, where you reach the pensionable age at 67, there are no productivity losses anymore. The additional QALYs achieved by this new device are 2. So the ICER is 10,000 divided by 2 is 5,000 euros per QALY. Let's now look at a second example, which is a medication to treat hypertension. And these examples are hypothetical, right? In adults between 30 and 60 years of age. total healthcare costs are again 10,000 euros. And the savings in productivity losses in the group that gets the medication are 7,500 euros. And the additional QALYs are again 2. What you can see is that in this case, because the savings in productivity losses are 7,500 euros, that in the end, the additional costs in the medication group are only 2,500 euros compared to the usual care group. Divided by 2 results in a QALY of 1,250 euros per QALY. So now we have 2 interventions that for the healthcare system have the same, need the same additional investment and result in the same health gains. But because we take into account the lost productivity costs for the second intervention, this results in a much more favorable cost effectiveness ratio than for the arrhythmias device. So including these lost productivity costs may favor the most economically productive members of society, and often that is white males. So you have to take that into account when you do economic evaluations, that the benefits that you gain, at least the financial benefits, may be much smaller in older groups or in groups that do not have a paid job than in other groups. So that's something to keep in mind when making decisions based on cost effectiveness analysis. I think I forgot to say that Angela will moderate the chat. So if you have any questions, just put them in the chat and Angela will make sure that they're being answered. So the other thing that often comes up is that people think, oh, it's only about cost savings. So it's only about saving money. And I asked Angela for a typical Brazilian example of this. So if you buy margarine, you can buy the Becel, which is 7.99 reais, or you can buy the QALY, which actually is a nice coincidence, Angela, which is 4 reais and 39. So who is, are there people in the group here who buy the Becel instead of the QALY margarine? Who is buying the Becel? No one? I think Angela raised a hand. Rodrigo prefers butter.
Yeah. People with
Karina buys Becel. Why do you buy Becel, Karin?
Gabriel as well buy Becel.
So why do we buy the Becel, not a QALY, which is much cheaper?
Because of the omega-3 and 6.
Yeah. So and then the apparently you value the addition of these how do you say that, these additional supplements so much that you are willing to pay 3.60 reais more, right? So that's the trade-off that you make. You decide whether the benefits of the Becel are so much more that you are willing to pay the 3.60 reais extra. And that's what we also do in cost effectiveness research. So it's not about identifying the intervention, the health intervention that's is associated with the lowest costs, but it's about balancing the benefits and the costs of the new intervention against the old intervention. So a new intervention can be more expensive than the standard care, but then the health benefits should be acceptable in relation to the investment that you need to make. And in the Netherlands, actually, and that's, I think that the people who have been to the Netherlands know that we eat a lot of peanut butter or pindakaas in the Netherlands. So in the Netherlands, I always use the pindakaas example because people have very strong opinions about pindakaas in the Netherlands. But it's always about the trade-off between health benefits and costs. So it can be more expensive, the new intervention, but the health benefits should be balanced against the costs. So it's always about the trade-off. The other thing is that when we use the cost effectiveness decision-making framework, we need to make a decision about the amount of money we are willing to pay to gain a unit of effect. So in the previous slide, I said it's about the balance of costs and effects. But when is the balance okay? When is it a positive balance? When do we say, okay, this is the investment that we need to make is justified by the health benefits that we gain by the new intervention? So we have to think about the amount of money that we are willing to invest as a society to prevent a death, to prevent one COVID-19 case, or to cure one case of cancer, or to have an extension of life of 1 week. So, and death or life is a pretty dichotomous distinction, right? So if you think about preventing a person from dying, how much money would you say society should be willing to pay for that? Do you have any thoughts about that? Would you be willing to pay 1,000 euros to prevent one death?
Hard question, Judith.
Sorry?
Hard question. It's so hard to put a price on that. In Brazil, we have no willingness to pay thresholds as well. No. And so, yeah, it's a big discussion about it. But maybe people from the Ministry of Health have something on this topic to share.
Yeah, so probably 1,000 euros to prevent a person from dying that doesn't seem like a lot of money, right? And probably 10,000 euros if we look in the Netherlands, and 10,000 euros is also acceptable. But if we talk about 100,000 euros, then the question is it feasible to spend 100,000 euros to prevent one person from dying? So I see some comments in the chat coming in. So
yeah,
it depends on temporal preferences. Fabiana, could you elaborate a bit on that, maybe? Or am I putting you on the spot now? Fabiana, would you be willing to?
She answered in the chat.
Yeah, in Portuguese, sorry. Yeah, you can talk in Portuguese, I can translate it.
Yeah.
No problem.
Ok. Eu acho que a nossa preferência, né, a nossa disponibilidade a pagar depende da nossa preferência temporal e, como ela tinha dito também, do custo de oportunidade que as pessoas estão ponderando, né, entre as outras coisas, entre as outras atividades, entre os outros casos.
Yeah. Fabiana just talked that the willingness to pay depends on the time preferences and the opportunity cost, because you are choosing something and you are putting the other things apart. And so you need to balance this, and actually time, it's a good point, because some people might be willing to pay now and not in the future. And so you need to take into account time preferences as well. And other people might want to have this in the future. So that's a difficult point.
Yeah, you never know whether there's budget left in the future, right? But it's also the point about if you spend a lot of money on one person now, do you have budget left to treat other patients as well? And preventing a death is quite a big health effect, right? But if we talk about 1 week of life extension, then the question becomes, is it wise to spend 20,000 euros to extend life by 1 week, if that means that you cannot provide a drug for another patient in the hospital.
Yeah.
So Anna says maybe we can prevent death with many vaccines for kids. So that's and you see that now, right, in the chat, that there are other aspects also coming into this in answering this question. So, for example, age is often a very important aspect that people take into account when they're asked about how much money would you willing to invest to gain a unit of effect. But it also depends on the health status of the patient. So does it mean if you prevent the death of a patient, does it mean that he or she can go back to his normal life again, or will he or she be bound to bed for the rest of his life? So it really depends on the health status of the patient before and after the health intervention. What you sometimes see is that also ethnicity plays a role in that, and especially in US experiments, that was a factor that played a role as well. And even though it's not your own money that you're talking about, your own budget, it does appear that people who have higher incomes are more willing to have a higher willingness to pay threshold than people with lower incomes. So there are lots of aspects that influence how much money people are willing to pay to gain a unit of effect. And I cannot focus yet now.
I must say that Gabriel think it would rely on the budget. This decision may rely on the budget. And Fernanda says that nowadays there are different models from willingness to pay that are being discussed, especially due to difficult to have a threshold. And so,
so as researchers, we try to avoid this subject a bit by creating cost effectiveness acceptability curves, which will come up in the course later over the course of the week. But it's, and Rafael also says that it seems to be the most critical aspect in health economic analysis. And I really agree with that, because our failure to state these thresholds also makes the use of cost effectiveness information much harder, right? And sometimes it's really clear. I mean, we had this situation in the Netherlands where there was this new medication for cystic fibrosis. According to the Dutch Healthcare Institute, it would cost about anywhere in between 400 and 800,000 euros per QALY to give this drug to cystic fibrosis patients. And then the decision is clear, right? That's not affordable. But even then, there's a lot of discussion in the media, among patients, in the parliament, the Dutch parliament, about that decision to say, okay, this is too much. So there's a lot of discussion about it. And I think that one of the main challenges in HTA in the upcoming years will be to create frameworks in which we can define such willingness to pay thresholds without having too much of these aspects like income, health status, and age diffusing the discussion about that. But this is one of the crucial points in cost effectiveness analysis. And the other thing is that often we, in the outcome measures that we include in our cost effectiveness analysis, we only look at health. And I included these pictures deliberately, of course, because this shows, so in the Netherlands, we have a very strong home care system. So we prefer older people to live in their own home as long as possible, but that often means that they need some nursing care when they are still living at home. So, but if you look at this older gentleman, then probably health improvements are not much possible anymore, right? He's around maybe 90 years old. Improving health is not the main goal of care for this gentleman, but it is making his life comfortable. Whereas if we look at, for example, the EURQUAL questionnaire, which is a questionnaire that we often use to quantify health benefits in economic evaluations, then the focus is on these health-related aspects of quality of life, whereas these are not most important to this gentleman anymore. So in a study that one of my postdocs did a few years ago, we looked at what kinds of aspects of health are important for older adults, and we saw that health is one of them, but there are a lot of other aspects that are important when evaluating healthcare interventions, for example, for older people or people who have severe functional limitations that cannot be improved anymore. And we also saw that these different aspects really tie into each other. So improving autonomy may also have an effect on relationships or on attitude and adaptation. So they are very closely interrelated. However, if you do not take into account these aspects, then you may conclude that an intervention is not cost effective when you only look at physical health. But if all these other aspects are improved, can you then really say that there's no benefit to that health intervention? So you need to be aware that health may not always be the most important aspect that's being improved by interventions. So you have to adapt your yardstick to the population that you are measuring benefits in. The other thing is, and I think you should have completed this exercise. So we have a framework that is called QualiLeague tables. And in these QualiLeague tables, what you do, I see there's a question, Angela.
Yeah, I was about to read, and Thiago Linhares asked, would a framework to define thresholds in healthcare analysis be acceptable? Some contexts, such as palliative care, pediatrics, and diseases that have a lot of public attention, such as breast cancer, would it be a knowledge translation challenge? But I think the question is there a framework to define a willingness to pay, taking into account those patients, those scenarios? I think for now, you did.
Yeah, so what you see is it's anecdotal, right? So there's a case that comes up. So with the cystic fibrosis, in the end, the company producing the drug and the Minister of Health in the Netherlands, they entered price negotiations, and in the end, the drug was funded from the healthcare insurance, but we cannot know the final price that is being paid by society. But these expensive drugs are coming up more and more, so we have to think about these willingness to pay thresholds more and more. And would a framework be acceptable? I think many people would not be in favor of it, but now we're making decisions, and it depends a bit on how strong the lobby of patients and clinicians is, whether we are willing to shift up our threshold a bit, or that we stick with the threshold that we defined. So I think a situation where we have a framework to define these thresholds and to define situations in which we may be willing to pay a bit more per quality or per life year gained would be preferable over the anecdotal decisions that we make now. So Now it really depends on how strong the lobby is. And I would prefer to have a framework in which we say, okay, when it is palliative care or pediatrics, then we're willing to pay more money. So I would really applaud such a framework.
So Rafael Leite is asking as well.
Yeah, so Rafael goes into the societal preferences, and he feels that one of the important aspects in Brazil is that if the new technology is addressing a disease that is where there's no treatment for yet, that may have an influence as well. And I think you see that in many countries, that if there's no treatment available yet, then probably we're willing to pay a bit more money. If it's for children, then probably we're willing to pay more money to per unit of effect gained. Yes, I think that's an important, and I think also the necessity of reimbursing a new intervention for a disease that has no treatment yet is higher than for a disease for which treatments are available already. Although the incremental cost effectiveness ratio probably will be more favorable then as well, because probably no treatment is less expensive than having a treatment available already, and the room for improvement, so the room for health benefits, is also bigger in that cases. So hopefully the incremental cost effectiveness ratio will be more favorable as well. Then Ayrton has a question. So about the role of the media. On defining health topics that are not a priority for society. Can you explain, Ayrton?
Yes, in several cases, the media hype in terms of a topic, sometimes it's not the priority, and it's very much on the headline, especially when a very important person, an actress, an actor, or even a politician has a very rare disease, and this is raise awareness, and also sometimes it's not a priority for the society, and people discuss it as a priority. I wanted to have your inputs in terms of the ethical issues that economic assessment can deal with it.
Yeah, so in general, so in the Dutch system, we generally are more willing to pay large amounts of money per effect gain for very rare diseases, because the budget impact in the end is not very high. If there are only 10 patients per year, then probably the budget impact is, well, limited. And these people, if you have the bad luck to get a disease like that, or to be born with a disease like that, then there are also less treatment options available, probably, if it's a rare disease. So in the Netherlands, it's not the media that influences that, but rather the fact that the budget impact of reimbursing an intervention for such a rare disease is not so high. And that we say, if you have the bad luck to have such a disorder, then as society, we think it's important to cover the costs of the treatment.
Thing is, from my experience here in Brazil, we have very frequently rare diseases, but not so rare. So the impact on the budget is very, I mean, it's great impact on the budget. So it's very common here. There's very expensive drugs for rare disease, but not rare enough. And there are a lot of examples. So some countries end up paying for that treatment, but sometimes Brazil go and pay, and it's approved but for the public system, but the impact is very large.
Yeah.
So
yeah, and then I think you have to go back to the framework and see whether well, whether the costs are balanced by the health effects that are being gained by the intervention, but also so what's becoming more common in the Netherlands again with these very expensive medications is that the health minister goes into negotiation with the company producing the medication to see whether the price can be lowered. And I think you see that in for example, the UK as well, that that's more and more the case.
yeah. So sometimes, I mean, most of the time, those drugs for rare diseases are not even cost effective in terms of, because it only improves a little bit of functional status, a little bit, but from the patient perspective, from the parent's perspective, that's so important. So we have this ethical, I mean, this ethical dilemma in terms of thinking about that.
Yeah.
Not only the impact on the budget, but even the cost-effective analysis are not, you know, not convincing.
No.
Because of the effectiveness. That's the problem.
Yeah, so either there is not sufficient effect or it's not measured properly. That's also possible, right? But that's an important point that you raise, that in very severe diseases, we're often so happy that there's something that every gain is seen like important, right?
Right.
Yeah, and that's an ethical discussion that we need to have.
From the standpoint of a physician with the patient, individual standpoint, it's a large beneficial effect. But from the standpoint of society, it's tiny.
Yes.
You know? So.
Yeah. So. It's not a discussion we're going to solve here, I guess, but it is an important discussion. And in the Netherlands, we have a separate fund for these kinds of very expensive drugs. But the Netherlands is pretty small, right? So, and we're the GDP of the Netherlands is pretty high, so we can do that. But I can imagine that in Brazil, it's much more problematic because well, you have a much bigger population. But also the income is lower, so I can imagine that is a much bigger problem that's not so easily solved by these administrative solutions that we find in the Netherlands for these problems.
Right.
And Rodrigo adds we still have lots of interventions without evidence that are being used in the healthcare system, and that's true. So in the Netherlands, we have a pretty clear system for medications, but like non-pharmaceutical products can just go into the healthcare system without being tested on cost effectiveness, which is a next step that we need to take.
And the price as well, I would say. But
and I think
it's the price.
Yeah. So nobody will question the effectiveness and cost effectiveness of providing a cast when you break a leg, right? But it's never been evaluated in a cost effectiveness analysis. But if you have a surgical robot, then the question, of course, is it cost effective to buy a surgical robot that's very expensive to perform specific surgeries. So then it will depend on how many different types of surgery you can perform with the robot, etc. But now these interventions can just be implemented in the system. And I think that it's not Diana, but
Karine.
No, it was the gentleman using his wife's computer. Jonas, yes. He says evidence is key to provide access. I think that neatly sums the discussion so far. So if we go back to the Quali League table, so that's one way to prioritize how to spend resources. So you order the Quali, you order the ICERs based on their size. And what you do then is that you reimburse the interventions that have the lowest ICERs until your budget has run out. So, and if you did a quiz, you played around with that, right? So you could see how much of the budget you would use up if you would reimburse the different interventions. And then you will see that there's a difference between fairness and efficiency. So the most efficient way to spend resources would be to go up from the most favorable ICER to higher ICERs until your budget runs out. So, and then you end up with 128 of the osteoporosis patients, and then that's the most efficient way to use the budget that you have. So the $20 million budget that you have. So then you spend 99.9% of the budget and you treat 87.4% of the patients. However, you can discuss whether Viagra or treatment of fungal infections of the nail, whether that are truly necessary interventions that you need to reimburse. So this was the second Quali League table was one of the Quali League tables that we ended up with in another group of students. So they said, okay, the Viagra and the fungal infections can go out, and we will only reimburse cholesterol lowering agents for patients who also have dietary restrictions. And then you can see that you spend 99% of the budget, but you treat only 57.5% of the patients. So whereas this is the very efficient distribution of resources, this is probably what we consider the fair distribution of resources. So we can never, ever make decisions based on quantitative evidence alone. So there are always other aspects that should play a role in whether we decide to reimburse a healthcare intervention or not. And only ICERs can never be definite in making that decision. Angela, was there a question coming in?
And Amelia has an additional comment, I think. As it practices in the public health system, a good aspect of following the guidelines is that they would have already passed through the eyes of the user in their approval and in the economic evaluation of their employment. These make me more comfortable with prescribing based on evidence and confident about the cost effectiveness within my competence with a family doctor gynecologist. So I think Amelia thinks that guidelines are reliable if they take into account all these factors, and then she feels comfortable in applying evidence bring by the guidelines.
Yeah, and I completely agree with that. And I think cost effectiveness is becoming more and more part of guidelines as well. So that's for us good to see. And that hopefully will help to make the distribution of resources more efficient in the end. So I agree with you there.
Yeah, and Luis as well. In this slide, in this example, what was the fair criteria to choose the 4 treatments? And so
yeah, that's subjective, right? So and there's always a lot of discussion about this between students. So some will say, well, do you need a PTA if you're still smoking? Or so there's always a lot of discussion about that. So, but probably I would feel more comfortable by this distribution, by the fair distribution, than the efficient distribution. But we have to be aware of, and that neatly goes to my final slide. We have to be aware of these aspects, right? That we make these decisions, and that we, depending on the lobby of patients, may make a positive decision about one intervention, whereas we decide negatively about another intervention. When we look at these fair distributions, then the criteria that we use are pretty subjective, right? So we need to make, and we do not need to put everything down in rules, but we, I think it would be good if we create a framework with at least golden rules, what to think about when deciding about reimbursing an intervention or not, based on cost effectiveness information, but also other information like if it extends life with a month, is that valuable or not? Does that mean that someone can put his affairs in order? Or so it really depends on the situation, but we need some guidelines, some ethical guidelines on what is important in making these decisions. So I think being aware of them is the first step, and being able to discuss them amongst researchers, but also with healthcare professionals and also with patient representatives, that will make the difference in the end. So that is my presentation so far. So are there any additional questions?
Judith, I was looking at the time. We have 10 minutes, and most of the quiz questions you have already covered in this in your lecture. And maybe we can skip the quiz and discuss. I can make it available, the solutions, and I can talk to them in the afternoon if there are some questions, because the solutions will be posted right after our lecture, your lecture, and so it will be fine. And if there is some questions, we can discuss in the afternoon or tomorrow morning as well. What do you think?
Yes, good idea.
Okay, then. Everybody agrees that we can upload the solutions, make it available, the answers, so you can compare with what you have answered. And if you have remaining questions, we are open to discuss in the computer practical and during the morning. Is that all right? Okay, then. Oh, good. I saw
lots of yeses coming in.
Yeah, good then. So we stick to the time and
yes,
go for lunch in Brazil, and us for a coffee. And we come back at 1 p.m. Brazilian time, right?
Yes. So maybe if there are any additional questions now, we can take a few minutes.
I was going to ask Angela that you could share the updated schedule that you have presented in the beginning on Moodle, so everyone could share. Yeah.
Perfect. I will do that. Definitely. Thank you. And also the solutions for the quiz. I will make it available right after this meeting. Yeah.
And the link will be the same as this one, isn't it, in the afternoon session? And
no, it's a different one.
Different
for
one.
The computer practical link.
Okay, yeah.
I can share with you the link.
You can share here on the chat, probably.
Perfect. I can do that.
And it will start 1:30 Brazilian
Yeah.
time, isn't it?
1 p.m.
1 p.m.
Where? 1.
Okay, then I wish you a good lunch and hope to see you tomorrow again.
Yeah.
Yes.
At 10 then. It will be 10 o'clock tomorrow.
Yeah.
Okay.
And the last point, are you going to present in Portuguese or in English this afternoon, you and Gisela?
I would say in Portuguese. We can go through all the computer practical in Portuguese, but of course, if you prefer one group in English, we can divide in both groups. But I would recommend to go all in Portugal so we can get all on the same page.
Yeah, yeah. So it will be a stick for having lunch.
Angela, just one question. We'll have the same 8 groups or will be less groups?
Will be 2 groups.
2 groups, okay.
Yeah, you just need to click on the link and be on the plenary section, and I will divide you into groups then. Yeah.
Okay.
Okay, then.
Just before finishing, you could send the link here on the chat, Angela. It might be.
Yeah, I have it already.
Oh, you have. Yeah, I see it.
Yeah, everybody got it?
Yeah.
Yeah.
Submit.
Yeah, great then. So have a good lunch and see you at 1. Thank you.
Bye.
Bye.
Bye-bye.
Bye.
Bye, thank you.